Bismillah ar-Rahman ar-Rahim. In the name of God, most gracious, most merciful. Let's start with the modestly prescribing guidelines combined study. And today's topic is the rapid tranquilization. So, first of all, what is needed and why is it, why do we need to rapidly tranquilize anybody? And before that, what can we do? So even before, you know before doing anything, even before verbal de-escalation, we need to know why is it happening, and why is it important to know why is it happening in a person is because the more we understand other person's viewpoint and put them in their shoes, then put ourselves in their shoes, in the patient's shoes, and then we know that what is the cause of that. And then, you know, then according to the cause, and sometimes in general, we need to treat the patient. So, what could be the causes? In psychiatric units, usually it's psychiatric illnesses, persecutory delusions, command hallucinations, other derogatory hallucinations. So all these things, tactile hallucinations, patient is becomes so agitated and paranoid that they start shouting and screaming. And then, welcome, Dr. Omar Habib. Welcome to the chat. So, psychiatric, and then it's the AV and tactile hallucination, then physical illnesses. So, physical illness sometimes can result in delirium or pain, and or due to pain or withdrawals, patient may be agitated and they can behave like that. And then substance misuse is another thing. Dr. Umar, please mute yourself. Thank you. So then, rapid tranquilization, practical measures. So we are going through the introduction. So what are the practical measures of rapid tranquilization? So you need to do some preemptive planning, that this happens. If this happens, what would happen? If this happens, what would I do? So you have to preempt the situation, and before, so even if, and that is the reason that why you should know what is the causing, what are the causes. That more you know the causes, you can treat it, you can nip this in the bud. So you can treat the situation even before it happens. If you know that the patient is flushing, their face is getting red, or they're getting irritable, just you can start giving, something. If it is oral antipsychotic, if it is verbal as de-escalation, if it is interviewing, empathy, anything you can do there and then, if you know the causes in advance. If they're physically ill, you know that they might go into delirium, and before they go into delirium, you can start treating the cause of the delirium there and then. If you know the substance misuse, you can start treating them quite earlier on. So, uh, rapid tranquilization. So, practical measures and advanced preemptive planning. And we should reduce the suffering of the patient and suffering to others. So patient is suffering, and the patient is and the others are also suffering. Other patients and staff members, they are suffering. Or if they are doing something in the for example in the public, so the members of the public are suffering, and then the patient themselves are suffering, then they can harm themselves or they can harm other people. So the first line is psychological and behavioral and interventions for de-escalation. If they fail, then rapid tranquilization. When we come to the protocol, we'll invite Dr. Seshni to throw light on verbal de-escalation techniques. So general principles: first of all, verbal de-escalation, then oral or inhaled treatment, or then sublingual treatment, sublingual asanapine or sublingual lorazepam. And sublingual lorazepam used to be available in Pakistan, but no more. And it is available only in the United States, not in the UK and Ireland. But I remember, like, Tanzil was the name in Pakistan, and it was a wonder drug. You put it and it would start acting straight away. Orodispersible olanzapine, again, it is not something rapid tranquilization, but it will get absorbed from stomach, but it is not a rapid tranquilization. So, uh, so it will get absorbed from the stomach itself, but not sublingually absorbed. And then it will do what it does in the same way as any other olanzapine. The only difference is that the patient cannot spit it out. Inhaled loxapine, not available in the UK and Ireland. Buccal midazolam. Parenteral options, then lorazepam, haloperidol, olanzapine, IM midazolam, and then uh, promethazine, aripiprazole, chlorpromazine. Sometimes combinations are needed. For example, loraz and haloperidol combination. And sometimes it is the haloperidol promethazine combination. These are the favorite combinations. Midazolam usually used on its own because it can cause respiratory depression. So it's better not to use midazolam with other drug and have flumazenil in place. Similarly, olanzapine should not be used with other drugs. And and then uh, IM ketamine can only be given by medics in usually the operation theaters, or in ICUs, but or in medical wards with all the facilities present, but not otherwise. So then the IV options: IV haloperidol, again used by intensivists, and they have all the right to use it because they are monitoring everything there and then. ECG is displayed on their monitors, so they can use it. IV haloperidol we cannot. IV diazepam we can very very rarely use it, but if we use, do not use anything else. Use it on its own and have flumazenil ready. Otherwise, don't use it. I've only seen IV diazepam being used only once, and it was without any haloperidol, without anything, and it acted straight away. So, so it's not very common. It's very very rare, and whenever you use it in healthy, fit individuals, and have flumazenil ready. Usually these things are given in ICUs. Side effects to be considered: acute dystonia, QTC prolongation, especially combination of haloperidol and promethazine. So there was a question came: why do we use haloperidol and promethazine? So because haloperidol will cause extrapyramidal side effects, and promethazine uh, will counter those extrapyramidal side effects. That's why we'll use the combination of haloperidol and promethazine, so that to prevent.
But sir,
Yes, please.
the promethazine inhibits the metabolism of haloperidol.
Yes.
So in a way, it prolongs the mechanism of action of haloperidol. But isn't that also toxic at the same time, causing QT prolongation and then another intense need to monitor the patient? I was saying.
Very good point. Very good point. So yeah, we can, but beforehand we must have ECG. If the ECG is showing, 410, 420, then you can go ahead with the combination. If the ECG is already, 440, then I would use lorazepam plus haloperidol, not promethazine. That is your answer to QTC prolongation thing. And then otherwise, we can use it. Dr. Omar, what's your question?
Thank you, Victoria. I have a question that is in Somalia, uh, we provided a combination sometimes for medicine and chlorpromazine. How you recommendation if he has enzyme weaken for haloperidol? There is a same category, and also sometimes they include haloperidol and magnesium combination to provide the patient agitation and violence patient well as recommendation
Okay.
that. Thank you.
Yeah, okay, Dr. Omar, I could not hear you very well, but what I would suggest is you start typing your question. When it comes in the chat box, I will try to answer it. Okay, thank you. So respiratory depression with the lorazepam and midazolam, it can happen, and then so yeah, the other thing is sometimes you, Dr. Benzi, your question is like promethazine increases the uh, levels of haloperidol, very well said, and that's why you don't use haloperidol 10 milligrams. You stick with 5 milligrams of lorazepam, or if it is and a kind of a very skinny individual or going towards elderly, you use even less. So, yes, side effects to be considered. Promethazine is an enzyme inhibitor for haloperidol, so that's why you need to be careful. But yeah, we have in the start of uh, psychiatry practice in 2001, we have used haloperidol and promethazine combination, and it was successfully used, and even now sometimes it is used. All we need to do is do not combine in the same syringe. Now, chat box. So, promethazine and haloperidol combination provide a patient. Yes, I have already told Dr. Omar that it is a good combination, but you should keep the doses. Maybe promethazine 50 milligrams and haloperidol no more than 5 milligrams, and it is good, and it will prevent against the extrapyramidal side effects. Now, respiratory depression can happen with lorazepam and midazolam. Protocol emergency situation, rule out medical cause, optimize regular prescription. Sometimes medication can cause, you know, uh, these things, or sometimes they are already on antipsychotic medication at a full dose. So then we cannot add another rapid tranquilization PRN. So that's you have to see the regular prescription as well and see whether they are already on antipsychotics or not. Chat box. So high dose 24-hour haloperidol. Tell us, doctor. So you see, in 24-hour, no more than 20 milligrams of haloperidol should go in the system. First of all, and secondly, the other thing is if it is IV haloperidol, it is only to be given by intensive care unit, ICU staff, not by us. So if it is, we should not prescribe it. They can, and they will, monitor it very, very slowly over hours and hours in slow infusion. But not, you're welcome. Okay, and then so aim is to calm, not to oversedate. Use lower doses for minors and elderly. So minors and elderly, of course, if you are using in a 16-year-old, you will go with 2.5 milligrams of haloperidol or even 1 milligrams of haloperidol. If they are drug naive, you will not even inject. You will give them oral and restrain them and give them oral, not injectable. Even if you have to inject something, then you will give lorazepam only to minors, drug naive. And if they are not drug naive, they have taken oral haloperidol before. If you have to inject and they are kind of repeat presentation, known diagnosis, then you will use 2.5 milligrams, but not in a drug naive person. Physical health monitoring is very essential. So now we come to the protocol and verbal de-escalation, and I will invite Dr. Seshni Moodliar, who is like a very senior trainer in psychiatry and does CAST training especially. So Dr. Moodlian, and her also her specialty is learning disability, in which you have to do a lot of verbal de-escalation. The patients are very small, having very small brains, small bodies, and very sensitive to side effects. And rapid tranquilization should be the very last resort in that population. So I would invite Dr. Moodlier to throw some light on de-escalation, how it is done.
Thank you, Kamran. Thank you so much. And that was really a good presentation. Yes, so the rapid tranquilization, I think you're using the Maudsley guidelines. So I've been looking at the verbal escalation techniques. So in terms of verbal escalation techniques, according to NICE guidance, which is available on www.nice.org.uk, you can have a look at it. Point 1.318, which I'm referring to, is the de-escalation techniques. If a member, so if a service user becomes agitated or angry, one staff member should take the primary role in communicating with them. So that staff member should assess the situation for safety, seek clarification with the service user, and negotiate to resolve the situation in a non-confrontational manner. So that would be the first thing that you would do. Obviously, we would obviously assess ABC as well. In terms of whatever's going on, we'd use the ABC approach. So looking at the antecedent, looking at the behavior, and looking at the consequence. And that would also be another way of identifying the triggers and how we could help that person in that situation. So the second thing they've said is use emotional regulation and self-management techniques to control verbal and non-verbal expressions of anxiety or frustration. So for example, looking at body posture and eye contact when carrying out the de-escalation. So I think from that point, Kamran, I don't know what you think, but I think it's about communicating to that person and then observing a lot of the non-verbal and verbal signs that we would be getting from that patient that's obviously quite agitated, and obviously might be quite frustrated in a high anxious state, might be very sort of agitated and aggressive, and potentially having some psychotic symptoms. The third point, which is 1.320, is use a designated area or room to reduce emotional arousal or agitation and support the service user to become calm. So in services where seclusion is practiced, do not routinely use a seclusion room for this purpose because a service user may perceive this as threatening. So I think these are all the main points that they are talking about. So it's a lot about communication. It's about using our skills as psychiatrists to observe. And then I think thirdly is looking at a place to find where we could actually use as a de-escalation to calm the person down. Obviously, I think the first and foremost, as you've already said, is de-escalation and then looking at medication. Um, Important as well, which they've highlighted a lot. It's a really good document to read as well, Kamran. So if anyone has a chance, I will get the exact document number and you can look at that. So what they're saying is that rapid tranquilization, learning about that and staff training is important. So anyone that's working, so including us in inpatient psychiatric settings, should undertake training in rapid tranquilization, in de-escalation techniques, in use of least restrictive practices, as well as in terms of like rapid tranquilization, the training you're giving us today. And then, yeah, there's lots of other information as well, but I think those are the main things, Kamran. Thanks.
Yeah, thank you very much, Dr. Moodlier. So yeah, as Dr.
Thank you.
said that like verbal de-escalation and the same staff handling the patient, and then sometimes one or sometimes more staff. So it's really what I said here in the beginning slides, is going to the cause of acute behavior. So if they are having persecutory delusions, empathizing with them without agreeing, that I can see you are really distressed, I can see you are really stressed out, you're frightened, you're absolutely frightened, I know. Let's go and talk somewhere, and two staff members will take the patient, especially if they're frail and you know that they will not do anything. You can calm them down easily, and you can take them to a side room and ask them what happened. If it was a behavior, for example, somebody disturbed them, listen to their story. So active listening. If they are hallucinating, acknowledging their hallucinations and acknowledging that it is very, very distressing for them. And then if their physical illness, delirium, substance misuse, you have to acknowledge everything. Even if they are delirious, you have to acknowledge that they are seeing something and it seems very, very real to them. So this is called validation technique. So you have to empathize and validate, uh, and then uh, this is kind of verbal de-escalation, and then coming back to the protocol.
Sir, I would like to ask a question. Since being secluded in a room with the patient, that can put a doctor into risk as well. So, how to minimize that risk, keeping in view the current situation we are working in, with not so many facilities? Is there a good option to take the patient to seclusion room, or is it better to communicate where other patients are and the nursing staff is available?
Okay, seclusion and isolation, two kind of different things. If the seclusion room is open, we will call it isolation. So it's an open door seclusion. People will be relatively more at risk. And if we are isolating, like secluding, then we have to close the door of seclusion room. Nurse and doctor stay outside the seclusion room. They do not go
Okay.
inside. They only go inside as a team, and the team is of 7 to 8 members usually. So maybe 3 or 4 will go inside, and and then uh, and then 3 or 4 will remain outside. Dr. Seshni, yeah, you want to explain that, please?
Yeah, no, sorry, Kamran. Yes, I'll come to that. I just wanted to say that the you gave an example about how to calm the person down. So in my book, in Past the Cask, in station number 57, the assault on the ward, the history, and then the management. So I've also used some questions and ways in which, so exactly what you said, in terms of explaining to the person, can you tell me what happened, and find out. So I've used the ABC approach and the triggers. So I think, and then looking at mental state, excluding mental state, as you said, looking at insight and checking their risk assessment in terms of past history of risk and current risk and any other risk factors like access to drug and alcohol, access to weapons. And then obviously, in terms of what doctor was asking, I think as I mentioned from the NICE guidance, sorry, Dr. Benazir, according to the NICE guidance, they did suggest if you do have a room where you can isolate the person, as Kamran was explaining, it's about isolation or using the seclusion room. So it depends. If you can de-escalate the situation, use rapid tranquilization, the medication if needed, and if the person is isolated in a side room, then I think that would be sufficient, and then the person can come out of that room. But if it's quite serious and the person it's quite like the person is threatening, violent, and ongoing aggression and risk of harm to themselves and others, then you would need to consider transferring them to a seclusion room. And if your ward doesn't have a seclusion room, then you can transfer them to another seclusion room, which is available on the hospital site, whatever designated seclusion room that is. And then you would have to follow the seclusion policy, because then the person will need to be monitored. So obviously, as much as possible, it's de-escalation, looking at the rapid tranquilization, the pharmacological management, and then considering whether the person can stay on the ward, be isolated, or go into a seclusion room. So there is various options, and I think at each stage it just needs to be managed with the MDT and documented exactly why the decision is being made. I think that's really important. So as much as Kamran, we're giving the advice about rapid tranquilization at all stages, ensure that you are documenting, because these are situations when things can go wrong and there's a lot going on. I know we've all been on situations. You must have been on the ward, Kamran, when you had to assist sometimes, helping with the restraint, helping with the de-escalation. Nursing staff are trying to get the medication drawn up. So a lot is going on. So just make sure that whatever you decide is documented, it's relayed and communicated to all the members of staff, and then managed appropriately. So these situations can be managed really well if you know the right techniques. And I think from what we're hearing today, the mostly guidelines and the NICE guidance, just to quote, it's the violence and aggression, short-term management in mental health and community settings, and inpatient, and it's NICE guidance NG10. So if anyone's looking for that, it's really, really useful about the recommendations and the research on that as well. And there's a flow chart. Thanks.
Thank you very much, Dr. Seshni.
Thank you very much.
We will try to share the NICE guidelines and G10 in our WhatsApp groups. Um, and it will be there on nice.org.uk. So yeah, and I think when I was teaching the FCPS OSCEs, I told you that ABC and HIPIC approach. Now there are two ABC approaches. One is an airway breathing circulation. That's something else. And the other ABC situation Dr. Seshni is talking about is antecedent behavior consequence approach. What led to this behavior? What was the antecedent? Was it hallucinations? Was it delusion? Was it somebody said to something to the patient? Was it psychological? Were they depressed? Were they manic? Or were they bereaved because of something? And was it provoked or unprovoked? Was it an internal provoking factor, or was it an external provoking factor? Was it biological or psychological or social trigger? And then behavior, what exactly was the behavior? And then consequences, how it was handled, and how it should have been handled. What were the staff responses? And was the patient showing empathy or not? And sometimes we do the ABC charts, an ongoing chart uh, about that, what's happening. And then the other causative factors. So somebody told me the HIPIC mnemonic. So the HIPIC is historical risk factors. So historically, has the patient done anything in the past? Or then something is illness related, drug related risk factors, or is there a past psychiatric history? Is there past medical history? Is there a family history? And then personality risk factors, and then the other personal risk factors, occupational risk factors, access to victim, access to weapon, all these things, how safe is the environment, all these things you have to. And then then the contextual risk factors. So and as in the, it's like nicely explained in Past the Cast. book, and it is very well, all the sentences are there if you want to read. So uh, let's open the chat box. Yeah, thank you, Dr. Seshni. And then use lower doses of minors and elderly physical health monitoring. Here now the other ABC come here: airway, breathing, and circulation. So you don't have only monitor the antecedent behavior and consequence, you have to look after the other as well, the other physical health monitoring: airway, breathing, and circulation. And especially when it's after you have given the rapid tranquilization, or if you have restrained the patient, or if you put them in isolation or seclusion. In all cases you have to monitor these things, especially if the patient is secluded, and you have locked the patient. We don't know what's happening inside, so you have to monitor them with a camera there, or with a glass door, and there are specific protocols of that. So yeah, nice.org and G10, yeah, and we'll share that PDF in the group as well very soon. So uh, so and then we have done the de-escalation oral treatment. Let's come to the oral treatment. So lorazepam 1 to 2 milligrams. So, lorazepam 1 to 2 milligrams you can give if patient is already on a regular antipsychotic, and especially if they're already having the BNF maximum dose, 24 hourly dose of regular antipsychotic, then you should not use any more antipsychotic. They're already on 20 milligrams of haloperidol. You should ideally not use another haloperidol, as a means of regular like the rapid tranquilization. They're already on 20 milligrams of olanzapine. You should not use haloperidol. So you should go with the lorazepam only, or maybe lorazepam plus promethazine if you want, but not an antipsychotic. So monotherapy with buccal midazolam or IM, it is unlicensed, and as compared to benzodiazepines, as compared to lorazepam, uh, midazolam does more respiratory depression, and that is why we need to be careful in using midazolam. So if we are using, have flumazenil ready, especially with midazolam. Not so much with lorazepam. Of course, with lorazepam you have to have it ready, but with midazolam you should be extra careful, and especially, and then the measuring the pulse, blood pressure, etc., and respiratory rate. So we don't normally use midazolam in UK and Ireland, and in Pakistan also it's not very commonly used. It's relatively uncommonly used. So the first line is more of a lorazepam than midazolam. If patient is not already on regular oral or depot antipsychotic, that's what the Maudsley prescribing guidelines say. And I would add, if the patient is not on a maximum daily dose of regular or oral or depot antipsychotic, or if the depot antipsychotic is not the maximum weekly dose, then you have some room to use the uh, to use the rapid tranquilization to some extent. So in chat box, yeah, hi Dr. Kamran, is there an alternative medication if my facility has no flumazenil? I am not aware of any other medication other than flumazenil, so I won't be able to comment on that. Or all I would say is that they look after the patient very well and keep their vitals, you know, monitored. And if it is going down and down, maybe involve the medics, and they may use some inotropic agents or something else to bring the respiratory rate back. Okay, so haloperidol 5 milligrams with promethazine 25 milligrams, not even 50 milligrams, maybe 25 milligrams, because we know that both the drugs interact with each other. So we can use increasing the dose of haloperidol via inhibiting the metabolism as a desired effect, but we'll keep the doses low of both so that QTC is not that much prolonged. Quetiapine, again, this is oral, so we're talking about oral, and we should try our best that patient does take oral. Do not jump on the injection straight away. So do not jump on parenteral, so, and do not even jump on oral first. So first of all, we should go with the verbal de-escalation techniques, then maybe oral if time permits, and if the situation is relatively less risky, patient is already on almost maximum doses of antipsychotics, then go with oral promethazine or lorazepam. Or if the patient is on very small doses of antipsychotic, then maybe go for oral antipsychotics. Do not jump for injectable at this stage. So give quetiapine 50 to 100 milligrams as oral even. Risperidone you can give, and in the West, risperidone quickly dissolving tablet is also available, and olanzapine is available in Pakistan as well. The oral dissolvable tablet. So use that so that the patient
Or
doesn't spit it up.
dispersible.
Sorry, say that again, Dr. Benzi. Sorry, you were breaking, so you can say again or you can chat. Okay. So haloperidol ECG is very much
Yes,
important.
sir. We have oral dispersible risperidone as well, sir, in Pakistan.
Yeah, you have the oral dispersible. Yeah, that's right. Okay, and then the haloperidol 5 milligrams EC with ECG, and yeah, we have oral dispersible. That's fine. And will Dr. Mavish asked, will verbal de-escalation work on deluded patient? Are there any situation where, yes, of course, sometimes there may be circumstances that you have to go on parenteral, but even then, okay, verbal de-escalation, even one word, if you say one word, that should be enough, for verbal de-escalation in those things. And and then after that you have to say another one word of oral, you know गोली ले लोगे, दवाई ले लोगे, ये लो दवाई खा लो. Just one word, and you have to just say. And if they are de-escalated, well and good. If they're not, then go ahead with the parenteral. Then again, try to stay with lorazepam or promethazine. But if the circumstances allow, then use 5 milligrams of haloperidol. So you have to consider these things in each and every situation. If the time doesn't allow, even then you have to say, will you take oral for me? If they don't, then go ahead. So you don't have to waste the time in that situation. And then so inhaled loxapine, we don't have it in the UK and Ireland. But bronchospasm patient, I mean, it can cause bronchospasm, and cooperation is usually needed. Salbutamol may be needed at times, so we don't use it anyways. And uh, repeat it after 45 to 60 minutes if necessary. So everything we have discussed can be repeated in 3/4 of an hour or 1 hour if needed. And this is we are talking about the oral, uh, like the rapid tranquilization. And now we come to the other intramuscular route. So combination of sedative and antipsychotic if necessary. So as Dr. Benazir said that promethazine and the haloperidol combination, it's not that much used, maybe due to that reason. So the most commonly combination used is lorazepam plus haloperidol, or even more common, which is becoming more common now, is olanzapine on its own, because olanzapine has sedative effect already. So with antihistamine, olanzapine has anticholinergic effect anyway, and that will prevent the extrapyramidal side effects. And olanzapine is a potent D2 blocker. So olanzapine on its own is becoming the first line now. Okay, consider IM treatment, intramuscular treatment. So lorazepam 2 milligrams up to 4 milligrams. Some centers may give up to 4 milligrams straight away, but some centers will say only 2 milligrams. So it's your own discretion. And in any way, under any situation, have flumazenil ready. IM midazolam is also an option, but flumazenil will be more important because there is a more respiratory depression, and make sure that the medics are there with a with a single call. They can come straight away if needed. So if you are in a general hospital, you can use midazolam. If you're in a psychiatric center which is remote, a satellite area, then try not to use midazolam. Okay, and then
So, sir, I have a question. Sorry to interrupt. So, I wanted to ask that, in the facility where we are working in our country, we do not have these intramuscular preparations of lorazepam or olanzapine or aripiprazole even. All we are left is with only promethazine intramuscular or
yes,
haloperidol intramuscular.
yes.
And as you know, that promethazine doesn't act straight away, it takes some time. It is a slow onset of action. So we are left with haloperidol. And in our setups, it's sometimes, or most of the time, it's very difficult to do pre-treatment ECG. So, I'm always ambivalent either to do it or not. This is the only option we have in Pakistan. So what should we do? We should take a risk, or
First
we
of
should,
all, you know, pre-treatment ECG is a challenge everywhere. When I was in England, it was a challenge how to do the pre-treatment ECG and then give haloperidol. So most of the times we were left only with uh, haloperidol, or only even only lorazepam. Most of the times we are left only with the lorazepam option.
okay. We don't have that in Pakistan, sir. No
Exactly. That's
injectables.
fine. That's fine. Then the alternative is promethazine. Go ahead with promethazine only option. If the patient is so agitated, vitals are stable,
Yes,
you can take the risk of giving 5 milligrams intramuscular of haloperidol along with promethazine in a different syringe, and use and do ECG as soon as they calm down. Do it इसको कहते हैं ना पहली फुर्सत में, do it in the first kind of opportunity. You have to do the ECG
right, sir.
in
Right.
that
Thank
situation.
you.
Okay, so uh, so that's about pre-treatment ECG protocol and lorazepam. So I think the ideal combination in Pakistan these days will be haloperidol and promethazine. In older days, it was haloperidol plus lorazepam. Okay, and then lower use lower doses for very young or elderly people, or people with brain damage, or with learning disability population, people having difficulties with impulse control. And promethazine 50 milligrams in a patient who has developed tolerance to benzos. So sometimes patients are taking. And another thing, Dr. Benazir, if the patient you have given haloperidol, you can offer them lorazepam in half an hour when they are relatively calmed down. You can offer them lorazepam oral.
Right.
so that the
Rather than repeating another injection after an hour, we should offer oral treatment then, yeah?
exactly, lorazepam, yeah. And even when you are repeating it, you have to, you have to offer them something as oral first. So olanzapine 10 milligrams on its own, that is becoming the first protocol nowadays. So, and you don't need to monitor ECG even. So this is the best, but unfortunately, it's not available in each and every country of the world. If it is available, go for it. So the only thing is not within 1 hour of benzos, and hypotension can be a side effect. So, and especially if you are using it with benzos, the patient may get respiratory depression. So be careful. And even in Pakistan, try to use the olanzapine orodispersible tablet in the first instance. If the patient takes it, well and good. Give them, if the oral, you can combine lorazepam as well, but with the intramuscular, you should not. So you can give some olanzapine and some oral lorazepam, oral olanzapine, and that will do the oral, but otherwise not together. Promethazine can rarely cause neuroleptic malignant syndrome. We discussed in the last lecture that NMS can be caused by these antiemetics. Similarly, with promethazine, it can happen. So it's a weak dopamine antagonist. So be careful. Promethazine can increase the levels of haloperidol. Aripiprazole acute injection is another thing we use from time to time. I've maybe used once or twice, so I don't have that much experience with that, but it works. And hypotension can be a side effect, but it is less prominent as compared to olanzapine causing hypotension. Haloperidol 5 milligrams as a last resort. That is the latest guideline, that olanzapine is the first resort and haloperidol is the last resort. But of course, if you are in a country where olanzapine injection uh, and lorazepam injection and aripiprazole injection is not available, then you will go for haloperidol plus promethazine, maybe considering promethazine first and then haloperidol, and in two different syringes. Acute dystonia can happen, better give it with promethazine and ECG before treatment, especially if possible. And repeat it after 30 to 60 minutes. So whether it is oral or injectable, you can repeat these things after 1 hour. In oral, it is 45 to 60 minutes. In case of intramuscular, it can be 30 to 60 minutes. And combinations can be tried: haloperidol plus lorazepam, haloperidol plus promethazine, and then do not give drugs in the same syringe. Consider IV treatment. So IV treatment should only be considered, if the patient is very, 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 very agitated and you are measuring the pulse, respiratory rate at the same time, you have flumazenil at hand, and ideally you call the medical registrar on call as well from a medical unit, and they also come if they can. Then you give IV treatment. Otherwise, better not to use it. If you end up giving it, give it a very slow injection. For example, you have a 20 ml syringe, so you can dilute it in a 20 ml syringe and give it 10 milligrams over 2 minutes. So you will give 5 milligrams per minute, and then the patient will be restrained. So that's how you can, the patient has to be restrained, otherwise you cannot. So the nurses and the other staff members will restrain the patient. And of course, when the restraining is, it's not like the police of some countries. You can't press their jugular veins, otherwise the patient will die. So carotid arteries. So you have to restrain them quite ethically in a non-harmful way. and you have to monitor vitals at the same time. And even if you can do the pulse oximetry to it there and then. So, and you can repeat diazepam up to 3 times after 5 to 10 minutes of each injection. Have flumazenil at hand.
So you just talk about the physical restraints. So I would want to have your comments regarding physical restraints of the patients. Are they recommended, or they should be avoided, or they can be done if really needed?
Well, after verbal de-escalation, physical restraint may be the first thing. If verbal de-escalation and oral things don't work, then you have to restrain the patient even before the oral. So you have to restrain them with their limbs. There are specific protocols. So you don't restrain, never ever patient restrain the patient with the neck or chest, you know, and or with their face or their head. So use their limbs.
So is it a common practice in West?
It is not very common, but yeah, it is done from time to time. It is needed. So use their limbs for restraining, and make sure that you are not breaking the limbs, or you're not causing any fracture, you're not causing anybody to get any harm. And Dr. Moodliar wants to answer that. So yeah, Dr. Seshni, please.
Yes, that's a good question. Yeah, so regarding restraint, is as I mentioned earlier, part of de-escalation is that you would be doing restraint as well. So there would be opportunity that sometimes if verbal de-escalation doesn't help, as Kamran was saying, then we would need to use the restraint, and that's the breakaway technique. So you will have to, so that's why I said about training, staff training. So usually we would have the required training. So we do breakaway techniques, restraint techniques, manual handling. So there's a different map. So there's different types of training in the trusts in the UK. I don't know about others, but we certainly will have that training that we would need to undertake. And during that training, so for example, in induction, we'd have the training, and they would teach us different techniques on how to actually manage a patient, because during a situation like this, it can become quite violent and aggressive if the patient is very agitated. So the patient might grab a staff member, or might start pulling their hair, or it might even attack doctors. It has happened, or attack other patients. So we would need to then, in those cases when the person is so agitated and there's obviously not a chance to give them a medication immediately, the restraint is done. So it is very common, actually. So we can go into more details about that, but I don't know how much of details you wanted on that. But that was the staff training that I was talking about. I'm just trying to check
Okay.
on the so on the guidance as well that I was talking about. They did say as well about the restraint. So it's worth having a look at that, because they have all the information about the restraint. So I'm just going to, de-escalation techniques. And then they said about staff training. So they need to be trained in this de-escalation techniques. And also, um, I think the only thing to say, when restraints can occur, body maps is important. So when a restraint is done, usually it has to be done in a way that obviously doesn't cause any harm to the patient. Like Kamran was saying, we're there to manage the patients, manage situations, and not to cause any harm. So it's about the manual restraint that we do. So the staff should have been trained. And so when you do the manual restraint, when it starts, one person will lead and then designate to the others what needs to be done next. So they say you don't use manual that interferes with the service user's airway, breathing, or circulation. So this is now from the NICE guidance. They've explained manual restraint. And then they say that, and nothing that can obstruct their eyes, ears, or mouths. You need to undertake manual restraint with extra care if the service user is physically unwell, if the person's disabled or pregnant or obese. You need to preserve the person's dignity and safety as far as possible. Sorry, Kamran, do you want me to continue reading these points?
Yes, please. Yeah.
There's quite a few. Okay, so do not use, thank you, do not routinely use manual restraint for more than 10 minutes. Consider rapid tranquilization or seclusion as alternatives to prolonged manual restraint. So if it's longer than 10 minutes on the restraint, you need to consider the others. Ensure that the level of force applied during manual restraint is justifiable, appropriate, and reasonable, proportionate to the situation, and applied for the shortest time as possible. And one person should be leading throughout the manual restraint and should ensure that the other staff members are able to protect and support the service users' head and neck, able to check the service users' airway and breathing, able to monitor vital signs and support throughout the process. And so it's important the service users' physical and psychological health. And they also say that so as we said, it's only for extreme, it's indicated for extreme violence directed at other people. It's indicated to limit self-injurious behavior. And also that it's consider mechanical restraints such as handcuffs when transferring service users who are high risk of violence and aggression between medium secure and high secure. In this context, restraint should be clearly planned as part of overall risk management. I think in the last point, I would say, as we said earlier, so we do obviously de-escalation. If that doesn't work, then we'd use the restraint. And then if the restraint doesn't work, then we would consider medication, pharmacological options. And then the third, the last thing would be, would the person be managed on the ward? Would the person be managed in isolation or in a seclusion room? And then sometimes in extreme circumstances, as they were saying, some people have to have handcuffs if they're quite agitated. And then we have to transfer them to PQ sometimes as well. So to other different secure settings. So sometimes they have to go to the psychiatric intensive care units or another unit on the hospital. So it's important that you manage that appropriately. So yeah, thank you, Kamran. So it's on the guidance. So everything's on there. It's quite a long read and there's more information. Thanks.
Thank you very much.
Thank you, Dr. Seshni. And while you were, teaching us, I just downloaded the guideline, and I hope this is the same which you were reading, violence and aggression, NG10.
Yeah, it's the same one. I saw that. Yeah.
Yeah. So I will share
Same
it
one.
with the groups as well. It is publicly available, and there are no copyright issues in that chat box. So. Let me maximum assert to everyone, physical and mechanical restraint is a mandatory training, and especially in old age it is very common happening, especially if a patient is at risk. As per Mental Health Act, if someone is restrained, must be physically checked by RMO, and whatever, like the duty on call doctor, and whatever happened must be noted in their clinical charts and must be informed to their nearest relative or next of kin. Multidisciplinary team must be informed. And and yeah, and there are cases when people have died in physical restraint or in the seclusion. There are more than one cases, and this has happened in the psychiatric settings, and not only in the police custody. And in the police custody, whatever has happened, we all know. So last year during the COVID breakdown, something happened around 2020 or 2019. So So we should not, like, the police also gets the training, and if they don't uh, act according to their guidelines, then even they are also answerable. So moving to the next slide. So consider IV treatment. We have done that. Because consider administration of IM ketamine. So only medics can do it, ideally in the ICU. They can also consider IV haloperidol, IV olanzapine, IV droperidol. ECT is also an option, but again, ECT will be something later on. First, you have to manage the patient's acute aggression, and if it is a repeated thing, then you can consider ECT. Uh, Now, physical monitoring during rapid tranquilization, before and after, and during the restraint. TPR and BP, temperature, pulse, respiratory rate, blood pressure. What is the most important parameter to monitor, and what is the easiest thing which can be monitored? Anyone?
Respiratory rate.
I was going to say that.
Exactly. Respiratory rate. Even if the patient is in the seclusion room, you can still measure the respiratory rate. You can see their chest movements, their lip movements, their nose movements, and air going in and out. And if you can, you can always check the pulse oximeter as well. So this is the most easiest thing, and you must look at this at all times. Uh, and blood pressure is another thing. So temperature, pulse, respiratory rate, blood pressure. 15 minutes for 1 hour. So for the first 1 hour, you have put the patient in seclusion, or if you have put the patient, if you restrain the patient, or you have given the rapid tranquilization, especially with the rapid tranquilization, which we are talking about today, you have to do it every 15 minutes for 1 hour, and then hourly until the patient is settled. So what happens is that every hour a group of nurses go into the seclusion room if the patient is secluded, or if they are isolated, wherever they are, they go to the patient together and they measure and they come out. And then every 4 hour the medical officer on call goes and checks whether it is the senior house officer or medical officer. So and then every 8 hours, uh, you know then it could be again, medical officer goes every 4 to 8 hours, and a consultant must see the patient at least once in 24 hours. And similarly, senior registrar can also see the patient 12 hourly, 24 hourly. So these are all the things which should be looked at. If the patient refuses for signs of pyrexia, hypoxia, hypotension, oversaturation, and general well-being, at least you can measure the respiratory rate. Pulse oximetry, one-to-one nursing is another thing. If there is no seclusion room, one-to-one nursing can be an option. If one nurse is not enough, two-to-one nurses. So two nurses to one patient, uh, and they will supervise the patient, keep an eye at all the time. It can be a, just adjacent with the patient, or if they don't feel secure or safe, then maybe they sit outside the room, outside the isolation room, and the patient is continuously monitored inside the room. So that can happen, but it is kind of one-to-one nursing. ECG, blood tests, you should keep an eye on blood tests, especially CPK or CK, creatinine kinase or creatinine phosphokinase, because if there is neuroleptic malignant syndrome, you can pick it up. Electrolytes for hypokalemia. So check electrolytes, because you're giving something which increases the QTC prolongation, and hypokalemia also increases QTC interval. So if the patient is already hypokalemic, then don't give them some IM antipsychotics. So the basically the protocol is every patient gets an ECG on admission. If we go by that protocol, these things should be in our baseline. And similarly, every patient gets the urea and electrolytes on admission. So if we are following that, these complications should not arise. If the patient was not hypokalemic at admission, most likely they will not be even now. If the QTC was normal at admission, most likely it will be normal after 4 days as well. So make sure that these things are done, and it is the duty doctor who is admitting the patient. They are responsible, and if they hand it over to the next person, then they should remind them again and again until it is done. And very commonly these things get missed, and I'm not talking about any one country. It's all, this is a global thing. If you are handing over something, things can be missed, and it is the consultant who should make sure that these things are done, because one passes on to another, other medical officer or house officer passes on to another, and these things can be missed. So the consultant should keep an eye, and as a responsible medical officer, you should keep an eye on these things of your own patients. If somebody hasn't done on admission, then it is your responsibility to get it done. ECG plus blood tests of every patient getting admitted to the psychiatric units. Remedial measures in rapid tranquilization. What if there is acute dystonia? Procyclidine 5 to 10 milligrams IM or IV. Start with oral, but sometimes IM or IV can also be given. And if you have a choice, go with IM, not with IV. And reduced respiratory rate less than 10 per minute, and reduced oxygen saturation less than 90%, then you can go with the flumazenil, I think. And then oxygen, raising legs, flumazenil, medical referral. Sometimes these patients may need mechanical ventilation, and I know, like when I was in England, patients were put on the ventilator straight after the rapid tranquilization in the accident and emergency department. And because it was done by the A&E doctors, we were not involved at that time, so it was their their responsibility. They did something and they did the remedy for that, and the psychiatry were involved a day or two after, when the patient started getting settled. So, and the good thing is, if they do that, they have these things available at hand. There is low pulse called medics, low blood pressure less than 50 diastolic, or if there is a postural drop of 30 millimeter, uh, between sitting and standing, call the medics. Patient to lie flat, raise their legs, and temperature. So measure temperature. There can be a risk of arrhythmia with the hyperthermia and NMS. So monitor CPK as well. And the next thing is how to use flumazenil. So I think I've only seen once it's being used when I was working in the medicine, and that was in the year 2000. So one of my colleagues, he's now a big consultant in Pakistan. So he was always enthusiastic and going along to the guidelines and acting on them. So he used flumazenil quite successfully in as an antidote in some benzodiazepine, uh, and coming with benzotoxicity patient. So it can be used as an antidote, and usually that toxicity, I think that happened with the overdose. So do not use if the patient has epilepsy or the patient is on long-term benzos, because what you will do with flumazenil is you will induce the withdrawals, and with the withdrawals, patients can go into seizures. So take a good history from the nearest relatives before using flumazenil. There is a caution with hepatic impairment as well using flumazenil. Dose is IV 200 micrograms over 15 seconds. If there is no response in 1 minute, give 100 microgram over 15 seconds. Another kind of dose can be repeated every 60 seconds, but the maximum dose in 1 hour is 1 milligram, that is 1000 microgram. So you should not use more than that. Again, it is usually the job of medics, but you should know these things in case you have to use it sometime. And side effects of flumazenil, so seizures, especially in a benzodependent patient, seizures can happen, or if the patient is having epilepsy. Anxiety, agitation, these things usually automatically subside. Monitor respiratory rate while giving flumazenil. When the respiratory rate, that's why I was saying respiratory rate is the most important parameter. When the respiratory rate returns to normal, stop giving it. Of course, you will be measuring other parameters as well, especially the pulse oximetry, because that will be correlated with the respiratory rate. And then flumazenil half-life is very short. Respiratory rate can drop once again if the effect wears off. So need to be careful. And and you might have to use flumazenil once again. So keep monitoring it. Consider other causes of sedation if flumazenil is unsuccessful. Maybe it is something related to opiates, and flumazenil will not work there. So consider these things. And now the last part of today's discussion, and I've said it many times, to the trainees, that zoclopentixol acetate or clopixol acufase, it is not rapid tranquilization measure. It is like a depot medication. It's like a 3-day depot. You give a depot injection which acts in the system for not for full 1 week, but only for 3 days. So it's between rapid tranquilization and depot medication. So consider it as a semi-depot. Do not consider it as a rapid tranquilization measure. It's a thioxanthine derivative and thioxanthine antipsychotic. Half-life is 20 hours. Duration is 12 to 24 hours. It is not rapid tranquilization. Because you give it, it may accumulate as a semi-depot, so it may, when it is slow release, then it may go for about up to 72 hours. So it's not, and the onset is delayed for both antipsychotic and sedative actions. So if you are giving it, it will not act straight away like haloperidol or lorazepam or promethazine. It will take some time, and it starts kicking in 2 to 4 hours. Peak action is after 8 hours, usually given to reduce number of restraints and reduce the frequent use of rapid tranquilization. So that's what happens. So if you have to give the haloperidol again and again and again, and lorazepam and promethazine again and again, you have to give all these things, repeatedly, then maybe at some stage your consultant may decide to give zoclopentixol acetate for the full duration of 72 hours, and that's it. So it should be a consultant decision. It has no role in rapid tranquilization. It's something to be considered after repeated RTs, olanzapine, haloperidol, and lorazepam. If someone had a good history of response to acufase, then it can be considered. But again, you have to give it at least 2 or 3 shots of haloperidol before considering it. Given if no response for 1 hour after RT, IM injections, or 15 minutes after IV injections of the other things, then you can, consider acufase. Otherwise, not, especially if the patient has taken it before. So do not give it as rapid tranquilization. Do not give it to restrained patient as risk of intravasation and oil ambulance can happen. So you can cause thromboembolism. So patient should be relatively settled, but that they will require another rapid tranquilization in some time. So then you can use it, but the patient should not be that much restrained in order to give the acufase. Do not give to neuroleptic naive patients. So do not give if the patient comes to the A&E and your first time you are giving it. No, it's not rapid tranquilization. There is a risk of prolonged extrapyramidal side effects. Plus, it will blur the psychiatric picture as well of a drug naive patient. You don't know whether they have gone to delirium, they have gone to dissociation after getting the treatment, or whether it was something as a baseline. Yes, Dr. Moodliar?
I think NMS as well. So NMS, neuroleptic malignant syndrome. So we need to be careful as well, isn't it?
Absolutely. And it can cause NMS as well, the clopixol echophase. Very well said.
Yeah. So, and that's a typical CAS question as well. So it's something you can read about and about how to manage that and how to discuss with the family what are the symptoms and signs. So, yeah, thanks.
Okay. So, yeah, that's it. Any questions?